Next, we have Dr. Mallika Arora, who doesn't need any instruction, a forceful speaker, has organized multiple conferences and is a chief retina consultant at Apollo Hospital, Hyderabad. She will be speaking on approach to retinal vein occlusions. Dr. Mallika.
Thank you very much, Dr. Gupta. Is it getting projected, please? Projection. Where's the audio visual? Okay, got it.
It's coming.
So, retinal vein occlusions, very common disorder, and the major risk factors are the usual risk factors for any vein occlusion: hypertension, diabetes, dyslipidemia, tobacco use, and less commonly homocystinuria, coagulopathies, and inflammation. And they also carry a higher risk of associated systemic cardiovascular and stroke complications. So patients should be made aware of those. The highest risk factor locally in the eye is glaucoma. So in a case of RVO, look at the disc very carefully. It's very easy to miss a glaucomatous disc. And if there is any doubt, do more investigations or refer to a glaucoma specialist. And if glaucoma is diagnosed, then avoid steroid injections for the RVO-related macular edema because that could increase the IOP. Similarly, guide the glaucoma specialist to avoid prostaglandin analogues and the alpha agonists because they could increase the propensity for macular edema which is associated with RVO. So this is a very common association which has treatment implications. Now, classification can be central retinal vein occlusion or a superior or inferior hemiretinal vein occlusion, each of which can be ischemic or non-ischemic, and branch retinal vein occlusions, which is a major vein or a macular vein, again with different treatment implications, because a macular vein occlusion will not have neovascularization, whereas a major vein requires every year evaluation for neovascularization. Now, what are the complications with these? We know with RVO, the most common is macular edema or ischemia, but also over time, neovascles on the disc or elsewhere. But most importantly and most dreadful complication is neovascular glaucoma seen in CRVO, hemiretinal vein occlusion, and also occasionally in BRVO. And conventionally, we used to say that it happens in the first 3 to 6 months, called the 100-day glaucoma. But since anti-VEGFs have come and we have started using them for the macular edema, we don't see neovascular glaucoma in the first 1 to 2 years. And it only comes up when we stop the anti-VEGF for the macular edema and patient suddenly comes with a painful blind eye after 2 years or 1.5 years. So the risk increases when we stop anti-VEGFs for macular edema. And even the non-ischemic cases that are initially non-ischemic very often progress to ischemic type. So we should not just say that it's a non-ischemic CRVO, so this will never develop neovascular glaucoma. They still need monitoring. So investigations include fundus photography. As we see here, it can document certain things which OCT does not, such as macular exudates, which resolved after a couple of injections. If we had just seen the OCT and the vision, we would have said that the treatment did not work. But you can see the exudates have resolved. So the patient feels happy that treatment worked. Of course, OCT is very important. It can document not only edema, but any vitreoretinal interface problems. And here showing spontaneous resolution of the traction, which often happens following PRP or even injections. Fluorescein angiography, very important to see the degree of obstruction, extent of capillary non-perfusion. It can even help to diagnose a BRVO in a long-standing case where all the other signs have resolved. And you can see the non-perfusion in that area, new vessels on the elsewhere or disc. But most importantly, fluorescein can show leakage from at the macula, which will guide the macular laser, which OCT angiography cannot do. Importantly, when there is some media haze from vitreous hemorrhage or asteroids, fluorescein can pick up the new vessels on the retina or disc or non-perfusion, which you cannot see clinically. So this is another indication for fluorescein angiography. And sometimes you can even pick up new vessels on the iris, which you did not suspect. The OCT angio is non-invasive and can show new vessels as well as FAZ non-perfusion. But the limitations are that it cannot show the leakage for macular laser in macular edema, and it cannot go into the periphery and mid-peripheral areas to show those new vessels compared to fluorescein angiography. Now treatment is, the first line is anti-VEGF injections, and early treatment is important. These studies have shown that even a 2-month delay in starting treatment reduces the number of eyes that will gain by 15 lines from 70% to 40% approximately. So just a 2-month delay can affect the visual prognosis. A recent study, the SCORE 2 study, comparing bevacizumab and aflibercept every month for 6 months for RVO, found that the visual results are similar for the two drugs, but if you see the anatomic results, complete resolution happens in almost 54% of aflibercept group and in only about 30% of bevacizumab group. So the anatomic results are superior with aflibercept. And then they found that non-responders, bevacizumab non-responders can be switched to aflibercept with good response. Another study, the LEVO study comparing the 3 anti-VEGFs, found that fewer injections are required when we use aflibercept compared with ranibizumab, and there is a greater proportion of patients with thinner macula using aflibercept compared to ranibizumab. Then this was a switch study, the Newton study, to see that if patients require very frequent injections every 4 weeks, does it help to switch them to aflibercept? And they found that switching to aflibercept, you could increase the treatment interval from 5.4 weeks to 9 weeks, almost double, an average increase of a month, with additional improvement in vision as well as CRT. Steroids are indicated in RVO despite the relative contraindication because of glaucoma. It is indicated when there are contraindications to anti-VEGFs. Avoid steroids in glaucoma, or if there is a history of infection or an immunocompromised patient, or if there is a large PC opening, scleral fixated IOL, where it can allow the migration into the anterior chamber, which is an emergency and can cause corneal decompensation. So what's the role of laser in RVO? In BRVO patients, it is indicated for macular edema. In CRVO patients, there is no role for macular edema, but it is indicated for neovascular glaucoma and neovascularization of the iris. Now, follow-up evaluation for RVO patients is very important. They have to have undilated slit lamp biomicroscopy and gonioscopy for iris and angle new vessels, a close examination of the disc for glaucoma and NVD, and then all RVO patients have to be seen annually, and peripheral examination annually for new vessels and proliferation, and very importantly also for fellow eye involvement every year, because very often they become bilateral and they are silent in the initial stages. What's the time left now? I'm not...
You can continue.
Carry on? Okay, so this is to show a patient of CRVO with some hemorrhage, pre-retinal hemorrhage, even at presentation. We did an angio which did not show any new vessels, but because of the hemorrhage, we still do laser and ranibizumab injection, despite which it progressed and had NVD. So we added laser, despite which it went into neovascular glaucoma. This is just to highlight that a patient of CRVO or HRVO has to be kept under very close vigilance for neovascularization of the iris and glaucoma. Bilaterality is very common as shown here, and it could be asymptomatic initially, so we have to look for bilateral RVOs. In the young, usually they are relatively asymptomatic, usually idiopathic inflammation, though there could be secondary to these TB, syphilis, HIV, sarcoid, SLE, and blood dyscrasias could be a cause, so look for leukemia, do a hemogram, oral contraceptive pills in ladies, and sildenafil in males, and now we are seeing even post-COVID infection and post-COVID vaccine. Generally less symptomatic with good visual prognosis, and systemic steroids can be used when nothing else is found, or even intravitreal anti-VEGF if there is significant edema. This is post-COVID vaccine. I had a couple of cases, very young patients, no comorbidities. This is 3rd day post-Covishield 2nd dose. And she had CRVO with inferotemporal BRVO, which resolved with oral steroids and anticoagulants without any further intervention. This is a young male, 11 days post-Sputnik vaccine and BRVO, which improved with steroids and anticoagulants, but required ranibizumab for complete resolution of the edema. And how we can correlate it was from injection of the COVID vaccine is the very high COVID antibodies, 3,000 almost, where just more than 50 is positive. Thank you.
Thank you. Thank you, ma'am. We know CRVO and branch vein occlusions are very recalcitrant edemas. It melts on anti-VEGF, but the rebound is very fast. The moment the effect of anti-VEGF goes off, the rebound edema comes very fast. So how do you counsel your patients in these type of disease?
Just like diabetic macular edema, we have to tell them that this is a chronic disease and the occlusion is not going to open now. We cannot reverse the occlusion which has happened. So we are only treating a symptom of the disease. So we do need to continue injections, and we don't know how many may be required. But possibly after 1 or 2 years, the number of injections may go down. So this is how we counsel. It is a long-term treatment.
Dr. Nitin, your view?
Yeah, sort of in addition to that, patients often ask, how long am I going to go? And we use a treat and extend pattern in Australia, and we normally find that at the end of about 3 months, when you've taken them up to 3 months intervals between injections, you get 2 groups of patients. Half of them can go to a sort of watch and treat or PRN thing, and half of them will still remain on regular injections, although may not be at 4 weekly. But I must say that the most dangerous time is when you start weaning these patients off the anti-VEGF, because that's when any neovascularization comes up, because with anti-VEGF you're suppressing them. And I feel that perhaps we have not given fluorescein angiography in these patients enough importance, because we don't do enough of that anymore. We always are treating the macular edema rather than treating the eye. So I implore you to don't forget in patients that you think might need it, which are most of them, do a fluorescein angiogram. It's going to give you so much information and it'll almost tell you which way the patient is going to go. The other thing is there's a group in Perth run, Ian McAllister and company, who have been working on chorioretinal anastomosis in selected patients. We're using a high-powered laser. They create an anastomosis between the retinal vessels and the choroidal vessels so that there's a bypass of the block, and you almost have a total resolution of the central retinal vein occlusion.
So, what's your recommendation when we should do a fluorescein angiography? Whether we should do right at the onset, or like what Dr. Mallika said, it's an 100-day glaucoma. So should we do fluorescein angiography somewhere between 2 to 3 months, or should we do right at the onset? What's your, Dr. Mallika and Dr. Nitin? What's your, when should be the timing of fluorescein angiography in branch vein occlusions and central retinal vein occlusion?
I would say it depends on the case. If you have enough suspicion at any point that it might be a proliferative retinopathy, that's the time we do it. So usually that suspicion is not there at the first visit. It will only start later, and there are maybe too many hemorrhages initially even. So, so I think it's never at presentation. It's probably down the line when there is a suspicion.
Dr. Nitin, your views?
I think a good time, just remember that when you're giving anti-VEGF agents, you're going to suppress any new vessels, and so the angiogram is only going to show you capillary dropout, non-perfusion, but not new vascularization. A good time to do it is when you're weaning off the anti-VEGFs, and perhaps when you're looking at, when they've reached their 3-month mark, and you're saying, well, should I leave this patient alone or not? You'll be surprised how many patients you'll pick up with, the need for panretinal photocoagulation or sectoral photocoagulation once you do a fluorescein angiogram. So I said, as long as they're covered with anti-VEGF and nothing else is happening, you're pretty safe. But the moment you start weaning off, that's the time to start thinking about it. So I'd say around the 10 to 12 week mark, when you reach that stage and wondering whether I can let this patient go on for longer.
In fact, I would say that if they are on anti-VEGF, you'll get a false negative FFA result, because the anti-VEGF would close the new vessels and you may not even pick them up.
Yep.
So will you prefer to treat areas of capillary non-perfusion if there are extensive, because in central retinal vein occlusion, you won't get a neovascularization at the disc or elsewhere.
So, see, if even with extensive non-perfusion, if we are anyway treating the macular edema, then it's probably not necessary to do any laser. But if we have stopped treating the macular edema, and as I showed a case, even though there was no new vessels, but it looked bad. So yeah, do a mild scatter and keep under very close observation, yes.
One thing important while doing a fluorescein angiography in retinal vein occlusion, especially in central retinal vein occlusion, you should do a wide field angiography, or you should try to look in the equatorial region, because ischemia is not central, it's a peripheral ischemia. So you need to laser the peripheral retina, not the central retina. So it's important to ask, if you are doing a fluorescein angiography, please ask or the patient to look in all directions so that you can catch hold of the peripheral retina, not the central retina.